There. Sorry to those on the line. We were on mute.
Oh, you didn't miss anything. And then we can find the spermatic cord, and this is what we start with. And basically, this is the entire spermatic cord, which has all of its fascial layers. There's 3 fascial layers of the spermatic cord that are developed from the fascial layers of the abdominal wall, all the blood vessels, the arteries to the testicle, the veins away from the testicle, lymphatic channels, and the vas deferens, which is carrying sperm. So all of that is there, and we start with it all because these nerve fibers are running throughout. And essentially, we start by opening up that fascial layer and basically stripping all of that fascia away from the spermatic cord so that we can get really at the nuts and bolts of the spermatic cord. And then we're left with this at the end. So instead, everything else has been stripped away. And what you can see here, this is the vas deferens. And so in men who are of reproductive age and who want to maintain their fertility, we leave this intact and we strip it from its surrounding tissues and all the microscopic nerve fibers, but we leave the vas intact. And then you're just left with a couple normal veins and a couple normal arteries so that the testicle remains healthy. Everything else is essentially destroyed. And the reason that it looks very aggressive is, again, because we cannot pinpoint a specific area where there's nerves. There's nerves everywhere. And so we go after them. We're like the Marines. And so we have data on 18 surgeries, all done by myself, and all have a reasonable follow-up. But this is something that we'll touch on towards the end. Is longer-term follow-up is certainly necessary for this. The ages are range. The vast majority of these chronic pain syndromes that we see in and around the scrotum, about 75% of them have a reason for it, a previous injury, previous infection, vasectomy, other kind of surgery, hernia repairs. And about a quarter of them have no identifiable source, or what we call idiopathic. And so we see a wide range of men, from very young to very old. I don't see anybody under the age of 18, but we certainly get close. The average pain scores are very, very high. And so when these guys get to see me, they are in trouble. These guys, again, it's very difficult for these guys to be seen in the first place. There is a complete lack of effective management. And oftentimes these guys have had other procedures done in an attempt to help, which in fact has actually hurt. And so the pain scores are very high, on the severe end of the scale, which just comes back to what we talked about in the beginning, with oftentimes these are incredibly debilitating issues for these guys. But after it, it's incredibly low. And we'll see that there's a large proportion of the men that have no pain at all. The overall success rate here in Prince George is 83%, which is right on target with what we see in the literature, particularly in series with similar sizes. And a complete response rate, the pain score of 0, in almost 2/3 of them. And in the rest of them, a partial response, which is a pain score of up to about 3, which for these guys they're very happy to deal with that. It's very manageable for them, and they're very, very happy. Failure is, again, something that we see. We saw that in 3 of those total, less than 20%, and again, very consistent with what we see in the literature. And like in true chronic pain fashion, sometimes it comes back. And a lot of this, we still don't really understand all the mechanisms, but like with chronic pain elsewhere, not only are there potential changes in the peripheral nerves, but there's changes in the central nervous system that a more focal approach like the cord denervation doesn't necessarily get at, because there's changes in the spinal cord, changes in the brain. But even in those cases of recurrence, very similar to the partial responses, the pain typically did not come back in the same fashion that it was before, and these guys were quite happy and found it very, very manageable. Complication rates, again, anytime we offer any kind of procedure, there's a complication rate. Hydrocele formation is very, very common, again, because we're getting at the lymphatics in that spermatic cord, which are responsible for clearing all the fluid that's developed around the testicle, and we had one testicular loss. The only comments I'll make about that is that this was in a case where the gentleman had multiple other procedures done on that testicle previously to help to manage the pain, which makes any kind of reoperative surgery is always much more difficult. So overall, the results that we have in our early experience here is absolutely comparable to what's published, which basically means that this is a very reproducible procedure, and most surgeons with particularly microsurgical training should be capable of doing. The risks are acceptable, the complications are acceptable, and it works. And it works much better than any of the other surgical options. And so it should be on the list and of things to offer men in these situations. And the newest guidelines put out by the Canadian Urologic Association does have it on their list, although access is a big issue, and we'll touch on that later. But again, these require long-term follow-up because the nervous system is a very, very tricky beast. And so we just want to make sure that these are durable responses in the long term. And what Davina is going to talk about is the quality of life issues, again, moving forward, because a lot of these guys have significant disability before, and we need to see how, whether or not we're actually making a long-term, a functional improvement in these guys, and that's what we're planning to do. Doctor.
So in our earlier conversations, we talked a lot about the novel surgery and then some of the opportunities that we had to really get to grips with the patient journey. And I think what struck me initially was really how challenging the journey seemed to have been. And that was just too good of a challenge for qualitative researchers to turn down. And so what's important to recognize is there's really a lack of knowledge in terms of the experience of the gentlemen that are faced with these conditions. So there is some existing literature around chronic testicular pain, but this is definitely on the most significant end of that. And that there was really an opportunity to explore that experience of the journey to surgery and then what really happened afterwards. And so to meet that, like, we have no real baseline of knowledge. A qualitative inquiry was most appropriate for that. And I elected to use more of a descriptive approach. And so this is an approach that's still based in a naturalistic inquiry. It's underpinned by constructivism, which recognizes the multiple realities that each one of us face by virtue of our histories, our experiences, our social location in the world. But it's a really great approach to help us explore experiences through an inductive approach, but to get an in-depth understanding of that experience without perhaps complicating it too much with too much kind of poetic language that sometimes qualitative research gets known to be associated with. And so really qualitative description allows for much more of a straightforward approach. And so it stays very close to the words of the participants. And it focuses a lot on storytelling and sharing the meaning that arises from those experiences. And I found personally in my own research, it's been something that's been most helpful then when I take that back to the clinical practice environment, because it is very raw, it's very real, and it's in a format that translates pretty well. So I should say that when we started to plan this, we looked at obviously who we were going to sample and so forth, and the process. And so very simply, we wanted a purposive sample, but without too much criteria. We wanted to see generally who is out there. And so we've invited every patient that's undergone this procedure. And to date, we've had 7 participants complete the interview process, and we're hoping for a few more. Although we're already seeing saturation in a lot of the themes and some big overlap there. These were recruited from the centre here in Prince George, and they were required to give informed consent in writing and verbally prior to the interview. And so to collect the data, we used in-depth semi-structured interviews. They were telephone interviews because the participants are located all across, well, for the most part, Western Canada, a few external to that even. And so we've had a lot of people that travelled long distances to access the service. And we digitally recorded those, we transcribed them, and then they've been analysed and coded and compared, and then organised into some preliminary themes at this point. And again, we're still ongoing, and so that may change as we go. And that we'll also be checking that back with our participants once we have our final analysis completed. But I should say when I started, I was pretty nervous. So my PhD was grounded in research with women. And so I'd had kind of a background in gender and research, but I'd never undertaken research specifically with men, and specifically with men and about their junk. So I was a little bit nervous. So I was like, how does this, how do I do this? So I think one of my first questions was, I think I need to hire a male research assistant because I don't know how comfortable someone is going to be talking about very private aspects of their lives with me. And I certainly, in my experience with women, is that if we were to talk about gynecological issues and things like that, there may not be that same comfort level. And I do remember Darby saying, you just start it off with a joke and then it'll be fine. A genital joke, I think, was the thing. But I couldn't I remember thinking how different it was, because if you were doing gynecological research and you made a joke, I don't think it would go down quite as well. So I was really feeling a little bit out of my depth. And I'll be honest, I approached the first few interviews with great trepidation. But what I will say is that I hadn't expected the findings. And so I've undertaken research on complex chronic illness. I've interviewed people at the end of their life. I work with people at their care for people at the end of their life. And so I've been used to tough conversations. I've been used to highly sensitive situations. But actually one of the interviews made me cry. And I've never had that in my whole research journey. And I wasn't really as prepared, I think, for, just how bad these guys have it. And you'll probably see that in some of the quotes as we go. I think what was also funny was my fears about being a woman interviewing men was quickly relayed. I found that the men were very happy to talk to me about it. And after the first few minutes, we were all very formal. We were, asking about testicles and things like that. And that within usually about 5 minutes, that even the language had changed to a point where at times I could hear myself like, oh, that's a new term. So little swimmers and all sorts. And so that, I was thinking how funny it was that there was a very genuine process of a relaxed exchange, and I was very happy for that. Oh.
Well, coming in apparently.
Davina shared.
I know. Sorry to interrupt.
No worries. And if we're not able to fix it, we'll make sure that these get sent out too. And so
right.
I'm looking.
Okay, and then we will share. Click start sharing.
Maybe that's better. Sorry for any folks that aren't able to see it, but we'll make sure these are available for you afterwards.
Yeah. No. E-World today might not be on our side.
That's okay.
Okay, that's everything I can do.
Perfect. Well, hopefully you can see it now, and if not, we'll make sure you get it. So I think one of the first big kind of components of the finding of the research was the experience of living with very profound pain. And I would concur with the evaluation done that most people, when they were asked about their pain levels over a period of time, typically reported their pain at around 6 to 9.5 out of 10, which in a palliative care world would be considered a critical pain emergency or a pain crisis. And so in terms of the trajectory of that pain, the pain often arose spontaneously, and it could have also occurred in response to a trauma or a surgical complication. So for a small proportion, that was injuries as a child, and some of the injuries were actually like just awful like traumas, and others were surgical complications, post-mastectomy and so forth. The chronic pain itself was debilitating, it was extremely isolating, and it was extremely limiting as well. And I think one of the things that was most commonly reported was a really high level of distress and trauma as a result of their pain, and not just in how they remembered their experiences, but also how they faced dealing with that trauma in a long-term way. So when reflecting back about their pain and their earlier kind of trajectory through the healthcare system, the management of pain was completely challenging. And so often they felt like it was trial and error, that nobody really knew how to help them, and they often bounded between different providers in the system. Sometimes the pain was, it was quite often many years. I think one of the participants was the longest, which was 12 years. And so it's an extensive period of severe limitation. And participants often felt that they were just left to cope. So one of the participants said that he was left to take over-the-counter medication, like on an hourly basis. And there was a lot of dialogue around medication and the choices that they were faced with. Another participant said, just give me something powerful enough that it's going to knock me on my ass. And another person recalled, it was bad enough I was going to kill myself to stop it. So the participants reported a great deal of despair and devastation, but also a need to push through. So chronic pain had significant impact on all aspects of the lives of participants, and that the solutions were often not forthcoming, and many experienced long days in even accessing the support and effective treatment. There was often lasting trauma, both in terms of how they were coping with their relationships and their onward life, but many also talked about the need to push through and the need to man up. One of the participants here said, I guess there's some kind of negative thought pattern that'll carry over, like, because when this was happening, I was like very limited and I just felt hopeless. And I got into this negative cycle of looking at myself and looking at the world that I'm still kind of working through and like that. So there's long-lasting emotional scars that are still healing. And this was someone that's now pain-free, but still felt very traumatized by a lifetime of experience. For others, the pain and the despair came also from a loss of independence. One of the participants recalls, I couldn't dry my lower body off. I have to get her spouse to come and dry my legs, to dry my waist, and because I couldn't bend over properly. A lot of mornings she would have to help put my socks and underwear on because I could barely reach far enough to do it. And these were common stories, and it was common across many aspects of life. Getting dressed, driving was huge. Even one guy said, it got to a point where I couldn't brush my teeth because when I brushed my teeth, his balls jiggled. That was his words. And it was unbearable. And it for the most part, they kind of likened it to being kicked in the testicles by a horse. And for another participant said, I had to stop working, and it was, I don't know, not sure what to tell you. I just about lost everything because I couldn't work, and it kind of shuts your whole life down. So financial, as well as kind of physical and emotional functioning, financial impacts of their experience were huge. And I was actually shocked that most people had impacts to their employment in terms of and also to their financial stability as a result of their chronic pain and the disability that went with it. And for many, it meant that they had to change the way they worked, so taking a different role in their workplace, especially if they were engaging in more physical work. One of the participants here said, when this happened, I obviously had to go on short-term disability and nothing was clearing up. they brought me into the office, and I've been in the office ever since. I've gone from 150,000, 200,000 a year to 65,000 a year. I just told myself to push through it, right? You need to push through this. You need to provide for your family until you get fixed. You need to suck it up, and you need to push through it, and I did. And so despite all the challenges, there was a real clear message that there was no space for their illness and their pain, and that for many, they had young families, and it just meant that life had to go on in some way or another. So a lot of the participants had a lot to say about their relationships as well. And it's a really sensitive topic to talk about sexuality, but the chronic testicular pain had major impacts on their relationships and also their ability to have a normal sex life. So chronic pain was isolated and impacted relationships within and outside of the home. And there was a lot of, I felt very strongly that the masculine identity was sometimes helpful and sometimes a detriment, and I'll touch upon that in a minute. But many felt the pressure to provide for their family, but also to maintain their relationships, including their own intimate connections with their partners. So in terms of their isolation and friends, so not to mention like relationships and friendships, it was like I wouldn't want to go out and do anything. And so that was a common experience, to feel isolated, to feel disconnected from the world. And so a lot of people felt that their relationships actually broke down because other people couldn't necessarily understand where they were coming from. And so in terms of masculinities, a lot of the participants talked about how they had support, but that support was kind of with the guys, and that it was kind of difficult. It was difficult. There was no real space for them to be vulnerable. And so often the support was more kind of camaraderie, and as one of the participants said, my buddies would just joke with me and be like, we can fix it. We'll just fix you like a bull, or we'll castrate you like a bull. We'll just cut them out for you, you know? And I think even though that was kind of the nature of the conversations that they had with their peer group, and so, yeah, I could really feel the isolation that a lot of people felt. And I think in terms of the relationships with their partners and their spouses, many of the gentlemen as well felt that their role in the family and their role as a traditional provider and supporter of their family also left no space for them to have kind of that, almost what they would consider a weakness. And so that notion of pushing through really came through in terms of the relationship as well. When talking about sexuality, there was actually quite a lot of conversation in the interviews about that, and I think one of the things I'd like to highlight is that actually there was a lot of unsafe practices around pain medication, and it wasn't isolated to, it was actually quite common across the population, and obviously it's a very small number of people, but to be functional and to have a sex life came at a price. And so often the participants would use their medication in quite unsafe ways to allow that to happen. One of the participants said, I'll go pop 5 morphine tabs, give me half an hour. It was, even on 4 or 5 tablets of morphine, it hurt like hell, but you can't not, right? You need that in a marriage and a relationship to keep you bonded. And then another participant said, if you had sex, it would hurt so bad for a week, you had to take way more pills to be able to have sex. And then another participant went on to say, my marriage broke down. I ended up, I'm still fighting depression. Yeah, just like the whole, just totally ruined your life. And so that was someone whose marriage broke down. And part of that was not having, the disconnects in that space and that support. And so the option of surgery took place within, after a long kind of trajectory of different treatments. Many had multiple surgeries in the past, lots of kind of injectable nerve blocks and things like that. And these, often raised the hopes of the participants, but also left them feeling in more despair. Indeed, one of the participants had told me that, at the peak of it, he'd got into a merge and he was just unable to cope. And they'd given him, the urologist had come and they'd given a nerve block. And he said for the first time he was pain-free. He'd gone from like a 9.5 out of 10, like complete pain crisis. And he said, I had no pain. And he said, I was 3 hours away, but I drove home. I got there in 2 hours, and I just ran into the school like a maniac and swung my daughter around. And then I ran out to my wife, who's in the car park waiting to pick his kid up. And he was like, just to be able to hold my child. And I think that was one of the most emotional intimacies, was actually, the price of the pain is so high in their relationships. And so he then went on to say he was pain-free for 3 hours and 8 minutes. And so a lot of the participants had faced a lot of disappointment in that journey, a lot of highly invasive procedures, and they were really at a point where they felt that there was no choice. And so this was considered really the last-ditch attempt, and most of them said they were willing to try anything at this point, just in the hope that they could get some relief. I had no choice. It was worth a shot. And then when I went to see him, that guy there, the night before surgery, he kind of says, I don't know if this is going to help you at all. And you're just like, you know what, I'm willing to try. And so I think that was really appreciated, that there was an option, because for a lot of these guys, they were in quite significant despair at this point. And another person had said that they'd come in for their second procedure, and how that experience had been incredibly positive. Although they'd had their pain fixed on one side, it had amplified on another, that they had come back in. And he said it was funny because I was there 1 year, and a year directly after, and everybody remembered me. And that's very special for a hospital to have it. It made you feel comfortable going to that hospital for my surgery. So a lot of people were very positive about their experiences here in Prince George, enjoyed the community, but I think most of all felt that they were treated really well. And so I think one of the biggest messages was when for almost all of them, they had complete pain relief, and some had very mild pain. But there was this overwhelming sense that this procedure had just handed their life back. I can ride bikes, I can go sledding, I can go water skiing and wakeboarding. Pretty much everything I used to do before, playing with my kids, my sex life, everything is pretty much normal. I feel like I'm 20 years old. And so this ability to relieve that pain provided many of them with a new lease of life. And that we also asked, and I think this is kind of relates very much to the next steps of where we want to go, is what could we do to make it better? What do you need at different points of the journey? And this is something we've been talking a lot about. And so for the most part, people wanted education, and they wanted to know that this option existed. And again, it was a very complicated path for people to get here. And so they've gone through multiple procedures, multiple specialists, and so people wanted to know that this was even an option. One of the participants said, I could see something like an outreach program or a testimonial website or something. I might help a guy go through it because he knows, hey, I'm definitely not the only one. And I think that was one of the things, was that people didn't know other people that had this experience. And so there was nowhere, again, it was very isolating. And another participant had commented about the need for emotional support. And I think most people felt that they didn't necessarily need it to be a full program, but there was kind of a definite need for some kind of emotional support, during that really intense kind of pain process. So I definitely could have had more emotional support during that time. Like if I'd had someone to talk to about my problem, would definitely have alleviated a lot of that emotional component. And so I think, again, it comes down to that isolation and not seeing other people like themselves. And for some of these participants, they were quite young as well. And so they'd lived this pain journey through puberty, and others in early adulthood. And so I think that isolation and that sense of belonging is quite important. And so
yeah, so moving forward, we just need to keep collecting the data, and we're doing, I think, a good job of that. Obviously we need more people, but we're getting more and more referrals all the time. And then what else can we do, in order to improve the education from the patient standpoint and as well from the referring physician standpoint, because there's a huge gap between treatment, diagnosis and treatment for chronic pain in general, and particularly for this. A lot of, it's a frustrating thing for patients to go through. It's a very frustrating thing for physicians to deal with. A lot of physicians don't deal with it, won't even accept these referrals, or send them to a psychologist or what have you. There's a huge gap, and I don't know what we can do to fill that gap, but there's certainly a lot of opportunity to do so.
And so I think the hope for us really in terms of that, how we share those findings with the members of the public, systems, targeted knowledge translation products that will maybe share the outcomes of our research, but also provide a brief kind of overview of chronic testicular pain and some places to access help. And so certainly in terms of the participants that took part in the qualitative piece, we saw people that had access to help through physiotherapists, through psychologists, and physicians and so forth. I think bringing some of those options together would be really helpful. And as you said, you mentioned that educational component for other providers in the health system, so that they may know kind of where to refer. And you talked about a little bit about the centralized referral process to kind of streamline some of the clinical care issues that would mean that those patients would get to you quicker down the line.
Right, and it should be relatively straightforward when you consider there's only 2 places that do it. But again, people are largely unwilling to see this patient population. They're often dismissed and they're often not referred. So, trying to take it out of their hands. A lot of the people that we see were self-referred, that they didn't even go through anybody. They just found this through, their own research or word of mouth. I'm very popular with the Canadian military, which is more of a reflection of how poorly they do vasectomies. But there's a lot of word of mouth, so there's a lot of opportunity there. We just need to figure it out.
Thank you so much. And if you have any questions, please.
All right. We don't know. Right. If we look at it's far more common than people think. And even if you just looked at a well-documented group of men, being the vasectomy population, that the rates of post-vasectomy pain, which this falls into, is 15%. In hernia repairs, it's up to about 10%. And so we don't have an overall number, but if you look at individual populations, it's pretty high. It's a lot higher than most people appreciate. Mm-hmm. Absolutely. Right. Yeah. We shouldn't, because we do when we again, we didn't go into huge detail of the surgery itself, but we're ligating and we're separating those nerve endings by about two centimeters. So they shouldn't grow back. What we don't have a good handle on is the changes that may have happened upstream, that we have a sort of this temporary impact on, but then all of a sudden this abnormal signaling is taken up by nerve roots or the spinal cord itself.
Challenges that you may face if you're working together and just trying to do almost some clinical collaborative work.
We're neighbors.
We live in the same area, so we knew each other anyway, which was a help. And I think there was just an interest in, it just stemmed out of a conversation really about the type of work that you were doing. And you have a very active, very humorous Twitter account too, which had some and so it just really stemmed out of a conversation, and I think for both of us, like, I was certainly intrigued, and it's really not a specific focus area of my research program specifically, because I don't necessarily have a urological focus, but in terms of that kind of patient experience, definitely that's always been an exciting thing for me. So I think I had a natural curiosity, as I'd heard more about the procedure, but also about the types of patients that were coming through and kind of the severity. We just had a lot of questions, and
well, and I think it was the responses, the early responses, that sort of led this to maybe there's something here.
I think I gave a crazy phone call to you, probably, which I usually do, but just so overwhelmed by the interviews and the power. Even in 7 interviews, which is really not a lot, it's so powerful and they're so deep. And I just felt very privileged that people opened up in a way that they did. Like, people had said, I've never told anyone this before. And so I felt there's a lot of responsibility that comes with that too, for me, of doing this really well and giving voice to a group that doesn't really have a voice. And I think the more, and then we just got super pumped with with hearing the stories, but also hearing, it's sucker for a good ending. And, for the most part, and you mentioned earlier, even the people that had, ongoing, what they would consider mild pain, which still at 3 out of 10 in the medical setting, we would still be wanting to do things, but they were so delighted. And so I think, I hope that this work will, at very least provide some education and some resources, at least for people to go through, to hopefully link people that are so isolated and so geographically kind of dispersed, because these are from all over Western Canada. And so
you mentioned that there was a code. If you study that
and so this is tricky as well, that with no code, there's nothing you can bill. And so right now they are being charged for it, simply so they can get it done. But again, hopefully with more literature and outcomes, particularly the long-term outcomes, that the changes to the fee schedule happen very, very slowly, but hopefully that'll be something that'll become more.
It's definitely in terms of health policy. I don't think the intention at this point is a policy briefing, but certainly if it's something long term that continues to grow, is that there may be an opportunity then to lobby through the ledge and through those ways to change that.
You mentioned it is guidelines now. Is it a very specific
No, it's sort of one of those, you know, if you read any surgical guidelines, they're all very poorly evidence-based, and so it's one of those on the options of expert opinion, but it's on there finally.
But I think part of that problem is a very, you know, it's a small population, I guess, that are so far having a procedure, and so it's very hard to translate that in best practice guidelines. Then, sure, you know, we probably don't really know the evidence. So.
No, but it's an incredibly commonly offered procedure in the United States for that reason. That's where the bulk of the literature.
Right.
No problem.
Thank you for having us. That was great.
Okay, we'll see you all on December 4th. Right? That's the date, right? Yep. December 4th. Okay. I don't know, Rachel, I don't know how to do this. I think I hit stop. Oh, can I just turn the phone off?